I have the opportunity to speak with patients who are newly diagnosed with prostate cancer. And the most common question I get is, what would you do? And it's really not that easy because, one, I don't have the cancer. I'm not living with it. I don't go home with it. I don't sleep with it. I don't wake up with it. So I can't truly tell them what I do since I haven't really been in their shoes. And it's not all that easy because not all prostate cancer is the same. And that's what we're finding more and more. That we used to lump all these people in one group or this group or that group, but the way we lump them is sort of antiquated. So let's go back. Traditionally, the annual physical exam, the PSA, which is a blood test to screen for prostate cancer, has been the only two ways that we sort of screen for prostate cancer. Most of the time, people have a normal prostate exam. And the PSA is a test that developed in the late 80s, and it's antiquated. It's a good and bad test. It could be elevated for many reasons, one, cancer, but just because it's elevated does not mean a person has cancer. And so now, today, fast forward to 2014, we're using other parameters, such as PSA velocities. We're using MRI of the prostate, which is a new technique to really look at the interior of the prostate. Instead of doing a biopsy, we use an MRI ultrasound fused biopsy, where we're taking MRI and ultrasound, marrying these two images, finding the target, and targeting it with our biopsy needle. And then once we get that diagnosis, and unfortunately if it does come back cancer, we grade these cancers as low, intermediate, or high grade cancer. But we're finding that a lot of people who we've traditionally graded as low cancer, if we elected to do surgery, are actually upstaged about 37% of the time to high grade. So our current grading system, or categorization we're doing for patients, is less than adequate. And here at the Urology Team, we're really pushing the envelope. We've invested in technology to allow us to image that MRI and ultrasound. We're doing these focus-guided biopsies to help better determine one's cancer risk. And if we do a biopsy, we're having good reason to do it because not only do we have an abnormal PSA, we may have abnormal PSA parameters such as a free PSA, and now we have MRIs that would suggest there's an abnormality, but more specifically showing us where that abnormality is. So instead of doing a random biopsy, we do a focus-guided biopsy, maximizing our efforts to find that cancer. And then once we get that cancer, we grade it and we look under a microscope and we use something called the Giesler score. But the problem with the Giesler score is just a picture. It's a snapshot. Prostate cancer is a living, breathing thing. Now we can use biomarkers, secondary pathology characteristics, and really know where the end game is. And determining on that, we can really risk stratify people. So I have people all the time come to me from out of town saying, I want surgery. I said, yes, you can have surgery, but is that really the best thing for you? And so we go through these things. We sometimes get imaging, such as MRI. We may send their pathology, not another biopsy, but the pathology they already had, to really personalize prostate cancer. And that's where it's going. It's personalization. I don't want to be lumped in a car with a group of people who are sort of like me. I want to be lumped in the car all by myself and figure out what's the best treatment for me. So that's how we feel here at the Urology Team, to really push that envelope, to really see how detailed we can get, to really, at the end of the day, personalize patients' care.